Good morning, everyone. I am Dr. Jessica Ryneic. I am a member of CCRM Boston Fertility's team, and I am here to talk about Fertility Treatment 101. And I have a lot to get through. Want to make sure we also have time for questions, so I'm just going to dive right in. So you've completed your evaluation. What comes next? Probably you're going to talk to your doctor about one of these diagnoses. There's a list here of many different things that can cause infertility, or you might have a diagnosis of unexplained, or you might even be single or an LGBTQ individual looking for options. And so now it's time to talk about what treatments are available to help you conceive. And just for some context, because I'm going to talk about what success is with different options, I want to make sure people understand what the chance of conceiving naturally in the first year of trying, once you've been diagnosed with infertility and on, because I think it's important to have those numbers in mind when you hear the success with treatments. And so you can see here, as we get older, the chances of conceiving do go down each month. With us in our 20s being maximally 25%, which sounds crazy to us, when we haven't learned any of this stuff, when we've been taught all our lives, the second we have sex, we're going to get pregnant. And then it goes down over time. And once you're over 40, the chance is less than 10%, and over 45 and above, chances become very low. And the reason that is because both the number of eggs that we have as women goes down over time. Not to say that infertility is just a female-based issue, but this is one of the main drivers of age-related infertility. Number of eggs goes down over time, as does the abnormal or the normal number of eggs that we have, and that provides hurdles. So, preparing your body for treatment. This is before even getting to all of the big steps that happen in the clinic. First and most importantly, share your goals and ask your questions. I think this meeting after the evaluation with my patients is the single most important meeting that we have, because it makes sure that we are all on the same page about what your goals are in building a family, what you're looking for, what treatment options just don't make sense to you as a family, and we can get on the same page so that we can make the best decisions about treatment for you together. And so you want to make sure your doc knows what you're looking for, how many kids ideally you're wanting to have, any concerns or reservations you have about specific treatments. I've had people tell me that they would feel very uncomfortable with having extra embryos, and IVF really just didn't make sense to them. And we take that into account. And you also want to make sure that you ask questions and understand your chances so that you can share in the decision making and also adjust your expectations as to what the outcomes might be. So once you've decided you're on this journey, or even, as you're starting to try to conceive before you're at this process, a healthier you equals healthier pregnancy and a healthier baby. And so, ideally we want to be eating a healthy, well-balanced diet most of the time. So that means limiting processed foods and fast foods, consideration of plant-powered eating. I know for some plant-based eating, including myself, is not actually possible at this time. And so, trying to limit servings of meat per day and making sure you're getting lots of fruits and vegetables is really important, especially that red meat we want to try to cut back on as much as possible. Having high omega-3s and healthy fats, and having an emphasis on whole grains, fruits, vegetables, olive oils. This can all lead to improved health and improvement in your chances of trying to conceive. We also want to try to maintain a healthy weight. Even 5 to 10% weight loss may help if you're overweight. But again, I don't ever have my patients go crazy with this. You have to also enjoy your life. And I think crazy restrictive diets don't help anyone. And so trying to, at the end of the week, say, I've had better decisions on a whole, and focusing on these small things can be helpful. We also want to limit exposures. You know, some of the reason that our eggs decrease over time and change in quality over time is because they're there from birth. And so everything that exposes to us throughout our lives can impact their quality. So if one thing for everybody, male, female, anything trying to conceive, stop smoking. That's kind of the biggest thing. You don't want to do any recreational drugs. Alcohol is okay in moderation. I usually tell my patients to limit to about 4 drinks or less per week on average. Again, reduce caffeine to less than 200 milligrams a day, and try to avoid toxic exposures as much as you can. Again, this is another big overhaul, trying to get all of this stuff out of all of the things that are in your house, but trying to be mindful as much as possible, you know, avoiding plastics if you can, heating plastics, and um, foods that are high in endocrine disruptors, because we can easily look those up and get those out of our diet as well. I always get asked about supplements, and so what are some supplements that might be a good idea for some people? These first 4 are what I recommend for everybody that's trying to conceive. Some of them will all be actually in your prenatal vitamins, so you want to take a look and see what your prenatal vitamin has, because it may have all 4 of these. So the folic acid is usually a component of prenatal. Vitamin D is very intricately involved in reproduction, and almost everybody that we check it for is deficient, and so I recommend everybody on vitamin D. A prenatal usually has about 400 to 600, and we usually want 1,000 to 2,000, so sometimes you need additional. And omega-3 fatty acids, which would be called DHA in a prenatal. These other ones I think are really great for some people. Acai is an antioxidant. I think it can be super beneficial, and there's some really good evidence that it's helpful for diminished ovarian reserve and age-related egg quality issues. Vitamin B12 is essential for vegans, and then for even more specific groups, inositol might be helpful for PCOS, coenzyme Q10, again, for diminished ovarian reserve. You know, I think that for most people, those 4 top ones are good enough. If you want to take more, the other ones are great, but also be mindful that we don't want to be taking 20 pills a day either. So now to get onto the actual fertility treatments, and you know, before we get into it, understand that there's multiple paths to the healthiest baby, and everybody's path may be different through this process. So what are the treatment options? We have oral medication with timed intercourse, intrauterine insemination with or without medications, in vitro fertilization or IVF, fertility preservation options like egg, sperm, and embryo freezing, and then advanced treatments, which would be things with third-party reproduction, which I will touch on really briefly at the end. So, oral medications with timed intercourse. Ovulation induction medications are typically used alone in couples with ovulatory disorders, so people with PCOS or other disorders in which the female partner is not making an egg regularly. We sometimes also use this with IUI, and we'll go into that a little bit later, but the goal of using these medications orally alone is to push the ovary to ovulate 1 egg, since it's not doing that regularly, in order to allow the chance for sperm to meet egg with timed intercourse or with IUI. Obviously, if you're not ovulating, you're not releasing an egg, and so there's no chance for egg and sperm to meet, and pregnancy is not possible. And so for these people who are not ovulating, this is a great option to try to make that happen. The most common options for that would be letrozole, which is also named Femara, or Clomid, which is also named Clomiphene. What these medications do is block estrogen, so that the brain senses that estrogen is low and pushes the ovary harder to mature an egg. As we are using these medications, you know, we start usually with the lowest doses, and sometimes increase the dose if needed if ovulation is not occurring. But most people do respond pretty well to these medications, and we can continue these, realistically for multiple cycles, especially if it's someone that's not ovulating, because as long as we can restore that ovulation, we can actually restore that age-related chance of conceiving. These medications don't make as much sense in someone who already is ovulating when used alone, because they don't increase the chances that much, given that the problem is not related to ovulation. Now, we do use these medications with IUI in things like unexplained infertility, or other causes of, subfertility that might not have like a great diagnosis. But it really takes the two of those together to make a difference for those diagnoses. So back to just the ovulation induction and timing intercourse. So timing intercourse, we want to make sure obviously that we are exposing the egg to sperm at the right time of the month. And so we can do that in multiple different ways. You can use your own tracking method, fertility-based awareness methods. You can do ovulation predictor kits, which work great for some people, not great for others. And so for those that ovulation predictor kits don't work well for, we can do blood work and ultrasounds, or if someone wants more data and feedback as to what's happening. It also is helpful if we use blood work and ultrasound, because if someone's not responding to lower doses of the medications, we can advance the dose faster because we can just increase it right away. If we aren't monitoring, we don't always have the opportunity to do that, because by the time we realize the ovulation hasn't occurred, it's already been a few weeks. We need to bring in for monitoring to figure out what's going on anyways. And this here, this graph just shows what happens in a regular cycle or in a cycle that's using ovulation induction. So this is an ovary on day 1, first day of your period. We give the ovulation induction medications typically between day 3 and 9. And as that's happening, it causes this one egg you see to get bigger and bigger, and then eventually to ovulate. So that's using ovulation induction with timed intercourse. And now we'll talk about adding intrauterine insemination to that process. So intrauterine insemination is based on the idea that putting a large number of sperm high in the reproductive tract may enhance the likelihood of conception. It bypasses the vagina and the cervix. It puts that sperm as high as we possibly can, as close as possible to the egg, without actually putting it together in a dish. So I like to say that it's kind of optimizing everything that we can outside of the body as possible. This is often performed with fresh partner sperm or frozen donor sperm. And so the morning of the IUI, there's either a semen collection or a sperm thaw. And then there's semen processing. So we maximize the number of motile sperm, which are the important sperm, to get up high into the uterus, and it concentrates the specimen. It gets rid of all of the stuff that we don't need to be there. These cycles can be medicated or unmedicated. So many people use Clomid or letrozole with this. There are a few people that still use gonadotropin injections with intrauterine inseminations. There's a subset of people that really benefit from that. And it can be timed by ovulation kits or with monitoring with very similar outcomes. The IUI procedure itself, so as I said, there would be a sperm collection or a sperm thaw the morning of, about an hour, hour and a half before the actual procedure. You would come into the office. The procedure starts with a speculum exam. That's the same device we use when we're doing a pap smear. A little bit uncomfortable, but shouldn't be too painful. We visualize the cervix, and then we have a catheter here connected to a syringe that has the sperm specimen inside of it. And you can see here, the catheter goes through the cervix, up high into the uterus, hopefully with the egg waiting here in the fallopian tube. After the IUI, no need to lie flat. Sometimes we have our patients, relax for 10 minutes just because it's a nice thing to kind of process and reflect, but there's no real reason that you actually have to do that. It's okay to resume usual activities, so you can go about your day. No need to not have work that day. It's also okay to have intercourse afterwards and before, during the cycle. We do often have people wait 48 hours before the actual collection. But during before that process or after the IUI, it's okay to also time intercourse if you have a partner that has sperm. And then 2 weeks later, you take a pregnancy test, and hopefully it's positive. This goes over IUI success, and I just, again, want to reflect back on what the chances were by age without any diagnosis of infertility. Maximally, we're about 20 to 25%. And so you see here, for under 35, it brings you back up almost, for some diagnoses, of course, to that 25% chance. The chance of success with IUI does go down as we age, but so does the chance of becoming pregnant by age. And so I tell my patients, or most of my patients that are doing IUI, that we can potentially bring it back up to that age-related chance. It does vary a little bit with what your diagnosis is, and so your doctor is going to be able to counsel you more specifically based on your unique characteristics, what to expect. We also know that there are diminishing success rates after about 2 to 3 cycles. There was a recent study, actually really great, that shows that up to 8 cycles can have a good cumulative live birth rate, but that was looked at in those that did not want to or could not proceed to IVF. I think most people would recommend moving on. Again, depends on the diagnosis, after 3 to 6 cycles. So then comes in vitro fertilization, and this is a big topic, so I'll spend a little bit more time on this one. So who is IVF for? Patients with tubal factor, male factor, carriers of a genetic disorder who desire to test for that genetic disorder in their embryos, if they've had lack of success with prior treatments, advanced age with desire to maximize success and shorten time to pregnancy and live birth. So some people use this as the first option, just given age or their family building goals. History of recurrent pregnancy loss and desire to test embryos for genetics, reciprocal IVF, or if you've frozen your eggs prior and are looking to use those. Is it right for you? This can be a really difficult decision. Discussing the pros and cons with your fertility specialist is really important. It can take a lot to make this decision. And so that's why I think that visit after you get your diagnosis and when you're talking about the evaluation and your treatment options is such an important one, because you really want to make sure you understand anything, what your chances are with each option, and what makes the most sense for you. So now I'll go through what the phases of an IVF cycle are. And so here is just kind of a general IVF timeline. You can see here cycle day all the way up to almost 60. So it can be, or it should actually be, a multi-month process. Now, the actual stimulation, which is the part that most people think about when they think about IVF or see it on TV, is only about 2 weeks. But there's preparation, and then there's stuff that happens after the fact that makes the whole process pretty prolonged. The shortest it can be probably about, those 2 weeks of stimulation, but if you've done the priming and everything, about 6 weeks, and that's if you do a fresh transfer. So the first part is downregulation or priming, and this is happening actually before you start your true stimulation or IVF process. And the goal of this is that we want to get your brain and ovaries ready for stimulation, so that all those small follicles that we see, and I'll show again another graph of that, all those small follicles that you have, we want to access those and get as many as possible to grow. And the reason that we want that is because the whole benefit of IVF, the whole reason that it works or has such higher success than our other treatment options is that we get multiple eggs. So rather than you ovulating 1 egg per month and then having to wait the whole next month until you ovulate another egg, we are rescuing eggs that are otherwise destined to die, and saving them and using them all at once. Now, we want to make sure all those eggs are starting at the same quiet starting point or baseline, to allow for optimal stimulation. And the way that we do that is with this priming or down regulation. Some protocols do allow you to start, as I said, right into the stimulation without any down regulation or priming medications, or circumstances may require that you do that. But other protocols may use birth control, estrogen, or even injections leading into the stimulation phase, to prime your ovaries, get your brain, your ovaries ready for this process. Then comes the ovarian stimulation. And again, this period lasts about 2 weeks. This is what most people think of when they think of IVF. And those daily injections of hormones that get your eggs to grow. These are called gonadotropins. They are the same hormones that usually cause your body to grow and release an egg, FSH and LH, but they're just in much higher doses. And there's a few different names or brand names for the medications. I listed a few of them here. But most of the time you're taking 2 injections a day, at least for the beginning part. Some people will do 1 injection a day. And this is the stimulation. The amount of follicles that will grow is based on your age, your ovarian reserve, and that's something that we determine with your evaluation, and the strength of your priming, and the dose of the stimulation meds that we have. So in order to know how you're responding, if we need to change anything, we monitor you daily with ultrasound and blood work to determine if we need to step up or down your doses. Importantly, we cannot stimulate more eggs to develop than your ovary recruits in a given cycle. And this is important for 2 reasons. One, for expectations. So we can get some expectations from the evaluation about how many eggs we might retrieve, but also this isn't hurting your future fertility in any way, because we only have access to that group of eggs that is coming from this cycle. So comparing this to what happens in a normal cycle, this is what I showed you before, where you have all these little small follicles. Only one of these follicles grows, and then it releases an egg, and all the rest of these little small follicles die, and we never get to use them. With a stimulated IVF cycle, on the other hand, so you see here, these are those gonadotropin injection medications that I was talking about, and you see there's a bunch of small follicles here, and more than just one of them grows. Hopefully many, or all of them. Almost never is all of them that we see at the baseline, but hopefully many of them grow in order for us to retrieve them and rescue them from dying. And this is just to kind of show you what happens during your IVF cycle. So on the left here, we have an ovary at baseline. So you can see, pretty dense. You can see small little follicles here. And then this is more towards the end of stimulation, where all those follicles have grown to be quite big size, and the ovary is much larger than it was at baseline as well. This accounts for a lot of the symptoms that you experience during IVF. I think another thing to really importantly remember, if you're on this journey, or if you think you might end up on this path, every egg that we retrieve comes from a follicle, but every follicle, unfortunately, does not necessarily have an egg. So I know it's really easy to get really invested in the numbers that you're seeing as you're growing your eggs and monitoring, but realistically, if there's not a follicle there, we're not going to get an egg from it. And not necessarily all follicle sizes will give us an egg. And so usually I give my patients a range of what we might expect, but I think this is something is really important to understand. So eventually during your cycle, your ovaries are going to be starting to make a lot of estrogen because you're making a lot of eggs. Your brain is going to think that it's time to ovulate because it doesn't know that you're going through IVF. And so all it has is that high estrogen level. It thinks an egg is ready to go, even if it's not. And so it's going to start wanting to ovulate. We don't want that to happen, obviously, because we want to control when you are getting ready to ovulate. So we do need to add a third medication to prevent ovulation. Now, some protocols have you start that right from the beginning. Other protocols do have you start that later on, and this would be a third medication that prevents that LH surge until we're ready to cause your ovulation. And that's what the trigger shot does. So when the follicles are ready, we have you give a trigger shot that causes those eggs to do their final maturation. It releases the eggs from the wall of the follicle into the fluid so that we can retrieve them. And after that point, 38 hours later or so, you are going to ovulate, but we do your egg retrieval between 35 to 37 hours later so that we can retrieve those eggs before that actually happens. The medications we use for trigger are very similar to the medication or to the hormones that cause ovulation. So traditionally HCG, which is pregnancy hormone, we use. We also can use Lupron or a combination of the two to get those eggs to mature and release. And then comes egg retrieval day. So the egg retrieval is a minimally invasive surgery. It is vaginal ultrasound guided egg retrieval. It's very brief, about 15 minutes. It does require anesthesia. Most clinics will use intravenous anesthesia, so you're asleep, but you're breathing on your own. You're totally monitored the whole time. Some places do use local anesthesia and just, conscious sedation. Where I am at, we use you're fully asleep. And you need to take the day off of work, obviously, no making big decisions within 24 hours of anesthesia. Some people will take the day after, but many people go back to work the next day. And then there's a semen collection that happens the same day, or a semen thaw if you have donor sperm or frozen sperm, and that's done to fertilize the eggs. And this picture here just depicts what's happening as a cartoon. It is the same ultrasound that we're using throughout monitoring, and there's a needle that's attached to it. There's a tubing that's attached to the needle. We remove the fluid from each of these follicles, and we send them to the lab, hopefully to find eggs. This is just a slide to show you how you might feel through the IVF process. Again, many of these symptoms are because of the growing ovaries and the hormones. So physically and emotionally, you might feel breast tenderness, you would have bloating, fatigue, headaches. Sometimes people can have hot flashes and dizziness, some nausea given the pressure in your abdomen. Injection site soreness, cramping, and then stress and anxiety, because this is a lot to be going through, and it's an emotional time even without adding all of these hormones. The risks are pretty low. There's a risk of bleeding anytime we do any kind of surgery, also a risk of infection. There's a risk of ovarian hyperstimulation, which is when the ovaries become overstimulated. We are very good at trying to prevent that these days, and that's what most of the monitoring is all about. And then there's a small risk of your ovaries twisting on their blood vessels, which is called ovarian torsion, which would be a surgical emergency. And that is the main reason behind why during IVF we ask you to limit much of your activity, especially towards the later part and after your retrieval. So after the eggs come out of the body, we've done the sperm collection or the sperm thaw, we fertilize the eggs. There's two methods to this. Conventional or traditional IVF would be when sperm and egg are placed in a dish and fertilization is allowed to occur overnight. ICSI is intracytoplasmic sperm injection, and with this, one sperm is injected inside each egg. It's indicated for male factor when PGTA is being performed or PGT is being performed, and it's also considered for unexplained infertility. Some clinics use ICSI for all, but these are the true indications. What happens after we do fertilization? The lab is taking care of the embryos, and this is why the lab is such an important part of what clinic you choose, because they're handling your sperm and eggs, and many of the outcomes depend on them. Day 0, the day of your retrieval, you know how many eggs you got. The next morning, you know how many fertilized. We grow the embryos out to day 3 or 5 if you're planning on doing a fresh transfer. Um, and day 6 and 7, we can consider growing the embryos out to that point. Um, if you are planning on doing genetic testing, you would grow them to 5, 6, and 7 and do a biopsy on those dates and then freeze the embryos. A note on pre-implantation genetic testing. This allows us to test for the genetics of the embryo. So there's 3 different categories here. One is for aneuploidy, which is an abnormal chromosome number. PGT-M is for single gene disorders such as cystic fibrosis or spinal muscular atrophy. And PGT-SR is for structural rearrangements, which might show a translocation, which can happen with recurrent pregnancy loss. Again, embryos are biopsied at the 5 to 6, 7-day stage. The biopsies are taken from the trophectoderm, which are the cells that are going to become the placenta, not the actual embryo. And then those cells are analyzed to see if there's a normal number of chromosomes or if there's those things we mentioned above. The reason that we do this, at least from an aneuploidy standpoint, is that chromosome abnormalities are the most common reason why older women see a decrease in fertility and an increase in miscarriage, and so this can decrease those risks. Once the embryos are made, we have some options for transfer. Again, you could do a fresh transfer with your IVF stimulation. And that could be on day 3 or 5. You could do a frozen transfer without genetic testing. So some people opt to freeze their embryos, let their hormones, let their body heal, and do a transfer later on. Or you could do a frozen transfer with that genetic testing. The embryo transfer itself is a pretty straightforward and quick procedure. There's no anesthesia for this, although sometimes we offer Valium, or we offer Valium to all of our patients. There is a full bladder, so you come with a full bladder. The procedure occurs under ultrasound guidance, so you can see that here. We do multiple checks to make sure that you are the one we are putting your embryos in, to make sure everything happens properly. Again, it's pretty quick. And then you're able to do, whatever you want with the rest of the day. Nothing too crazy, but most people, or some people, go back to work. Some people take the day off. There's no need to be bed rest. And we find out, depending on what day embryo was transferred, 9 to 11 days later, whether or not it was successful. If it's successful, you need to continue some medications to support the pregnancy until the placenta takes over, and that's around 8 to 10 weeks of pregnancy. The most important one is progesterone, and that's either vaginal inserts, vaginal gels, or injection, or a combination of those. And then oftentimes you'll continue on estrogen for that time period as well. So after the transfer, up until about 10 weeks of pregnancy, you remain on these hormones. So what is the success of IVF? I have 2 different tables here. This was the data from SART in 2018, so all cycles that reported. And so you can see here, these chances are a lot higher than what we were looking at with natural conception and with other options of fertility treatment. And that's, again, because we have multiple eggs. And so all cycles reported under 35, live birth of about 63%, 35 to 37, about 53%, 38 to 40, about 40%, 41 to 42, about 22%, and then 43%, 43 plus, about 7%. Now, just to compare with when you use PGTA, so you take out that abnormal chromosome number, those chances can actually become quite even across the board. Now, it might be much less likely to make a normal embryo as we get older, but if you have that normal embryo, the live birth rate can be just as high. And so you can see here in this other chart, which looks at the CCRM network internal data, from 2007 to 2018, it's pretty even up to about 40 years old, and then a little lower as we get older, but we're less likely to make a normal embryo at that time, but very high chances of success. Just to touch on briefly what other options are. So I talked about third-party reproduction earlier on. So this would be using donors to complete your family building for whatever reason, whether single, LGBTQ, um, poor quality eggs or male factor. You might want to use donor sperm, donor egg, or a gestational carrier in cases of recurrent pregnancy loss or implantation failure. These are all more advanced options for fertility treatment. There's also family planning and fertility preservation options, which would all be kind of very similar. Egg and embryo freezing are very similar to the IVF process. Sperm freezing is very straightforward, just be doing a collection and freezing vials of sperm. And then LGBTQI options really would be all of the above. So IUI with donor sperm or without donor sperm. Reciprocal IVF is when one partner of a lesbian couple goes through the IVF process and makes the embryos using her eggs. The other partner carries the pregnancy. Third-party reproduction obviously is open to this community as well as fertility preservation. So I'm not sure how long I talked. Hopefully I'm under and have enough time to go through as many questions as everybody has. Thank you for being here. I love this conference. I'm really excited to do it for the last couple of years when I joined CCRM Boston. I am available for any questions now. I'm always also available, either via email or on social media.